Okay, so in primary hyperoxaluria, it's a little different than most of the kinds of chronic kidney disease that we study, like say diabetic nephropathy, where blood pressure and treatment of protein is important. Those things aren't really issues in primary hyperoxaluria, so we're much more focused on things that would reduce the oxalate excretion in the urine as well as decreasing their rate of crystallization. So things like drinking a lot of fluids, using things like citrate or phosphate to keep the crystals from forming in the urine. And then the newer strategies to try to decrease oxalate production with either newer RNA type treatments or other ways to eliminate it through the gut, for example, enzymes that degrade it. So I think there's a lot of pathways coming together in PH that'll be quite different than what we do for our routine type patients with chronic kidney disease.
Okay.
So I think number one, that we had a patient with type 2 primary hyperoxaluria, and he had a combined kidney liver transplant, and the liver transplant normalized his excretion of oxalate as well as glycerate. So this does suggest that if you correct the liver problem in PH2, it will reduce oxalate excretion much like it does for PH1. I think this suggests that strategies aimed directly at the liver would be effective in type 2 primary hyperoxaluria. And finally, it suggests that most of the oxalate in that is actually coming from the liver. So even though the enzyme is present to some extent throughout the body, that the liver is really where the oxalate's coming from in type 2 PH.